This is chapter 21, anaphylactic reactions. So you get called out to this Thai restaurant. You have a 28-year-old female. She has hives and itches, and you do your sample history, you do your assessment on her, and she says that she just finished dinner, had a Thai salad, and about 5 minutes after she ate her dinner, she started to feel nauseated and then developed the hives and the itches. This is a pretty common scenario that you run into. And it turns out, as you ask her your sample questions and you get a history on it, it turns out that she has allergies to peanuts. And she's expressly told the waiter, I do not want any peanuts in my dinner because I have allergies to peanuts. And he said, hey, no problem. The problem with this is that even the most minute amount of peanuts or peanut dust or peanut oil, if she ingests it, it can affect her. So obviously what happened is a small amount of peanut substance got in her meal, and now she's having an anaphylactic reaction. Now you see her face is all swollen there. That's called angioedema. And what happens with that is due to this reaction, the capillaries leak around the area of her face, her neck, her shoulders. And when those capillaries leak out, they leak out plasma, causing edema, causing swelling. It can be swelling to her throat, her face, her tongue, around her eyes. And those are just, if you see that face, that is a serious allergic reaction. And even though not everyone who has an allergic reaction gets angioedema like you see here in this picture, it is a common finding along with the hives and itching. So let's talk about the pathophysiology of all of this. Now, we all have immune systems. We all have an immune response. And the way our immune system learns is literally by doing. It comes into contact with a substance, something enters the body, it builds antibodies against that substance to protect the body. Whether it's a virus or whether it's a peanut or whatever it might be, it builds up antibodies. Now, these allergens, these things like peanuts and shellfish and dust and all those different types of things create all different kinds of reactions. I'm sure there's some people that you know that have hay fever. Well, when someone has hay fever, that's a very, very mild allergic reaction to the pollen that they're getting in their eyes and up their nose and in the respiratory tract. And you can have localized reactions, like you could come into contact with poison oak or poison ivy. That's a localized allergic reaction. It's called contact dermatitis, basically. You could be a person who gets stung by a bee, and the bee sting, obviously envenomates you with that protein, but you have no serious response to that. So you get a raised area at the site of the injection. It itches, it hurts. It's localized to your forearm or wherever you were envenomated. It doesn't spread throughout the body. Once your body becomes hyperreactive to a particular substance, you then start to have problems of what's called a systemic reaction. The whole body starts to react in an adverse way. Now, there's mild systemic reactions. And this would be someone who has been envenomated by a bee and they've got some itches and some hives, but they have no swelling to the face. There's no respiratory or any circulatory involvement. It's purely limited to their skin. And these people do really, really well. But as soon as this systemic reaction, this whole body reaction, starts to affect their respiratory system or their circulatory system, or both sometimes, it becomes an anaphylactic reaction. And the definition of an anaphylactic reaction is a life-threatening allergic reaction. Now, how this all happens is, of course, our body comes into contact with a substance, it becomes sensitized to that substance. And unfortunately, this particular individual, they have a hypersensitive immune system, especially to one or a few substances. And when the body reacts, initially, let's say let's say you're 8 years old and you get stung by a bee, and you have a mild systemic reaction. You itch all over, you get a little bit of hives. Your mom gives you some Benadryl, and it goes away. 5 years later, you get stung by a bee again. But the problem now is that your immune system's already been triggered. It's already hypersensitive to that bee sting. And what's going to happen is now you're going to have a more serious, more violent reaction. Now you're going to have maybe the angioedema. You're going to get a lump in your throat. You might have some breathing problems. Your blood pressure might drop a little bit. And you go to the hospital. They give you epinephrine and Benadryl, whatever you need for this reaction. And then say 5 years after that, you're now 20 years old and you get stung by a bee again. And now you have a really super serious reaction. Each reaction gets subsequently more intense and more dangerous because of this original exposure to whatever you are having this hypersensitivity to. You can see that these mast cells release histamines, and if you ever know anybody, like I said, who has had or has hay fever, the reason why their eyes water and their nose runs and they get itchy is because it's this response to those pollen particles, and histamines are released and they cause your eyes to water and your nose to run and for you to cough to get rid of those particles. So that's a mild histamine reaction. When you have a serious anaphylactic reaction, you have this gigantic uncontrolled cascade of histamines. And when you flood your entire body with histamines, it can have some really negative effects on your respiratory and circulatory systems. Now, we talked about anaphylactic responses, and an anaphylactic response, by definition, is caused by a previous exposure to whatever you have a response to. So you had to have some kind of previous exposure to the peanuts or the bee sting, and it gradually increases. There is one type of reaction that does not require any sensitization, and this is going to be the anaphylactoid reaction. And I've seen a couple of these in the field. They have no previous history of allergic reactions. They have no previous history of any kind of serious response to any substance in their lives. And suddenly, out of nowhere, they go from 0 to 60. I've seen this happen a couple of times, and in both cases, it had to do with penicillin. In both cases, these people had an infection. They were given oral medications, in this case penicillin. They took their penicillin for a day or so, and within about 24 hours after starting their course of antibiotics, they went into a full-blown anaphylactic reaction. Now, it's not just penicillin, but it seems to be usually some type of medication. I've heard of it happening with bee stings as well. You just got to listen to the history of what's going on. And they're not going to have a history. They're going to say, I've never had an allergic reaction before ever in my life. I've eaten peanuts before. I've been stung by bees before. Or I've never been stung by a bee before. I've never had a pizza before. Whatever it might be. You also get this sometimes with soaps, perfumes, and things, body lotions. Some brand new body lotion or some brand new perfume they've never used before can set them off. It's pretty much the same signs and symptoms. It's pretty much the same. It's the exact same treatment. You're going to give them epinephrine, high flow oxygen, and rapid transport to the hospital. Causes of anaphylactic reactions are many. These are some of the obvious ones we talked about. Shellfish, peanuts, bee stings. What I'm seeing a lot now in kids especially are wheat allergies. So these children can't eat any type of wheat product, or they go into anaphylaxis. I've seen things like I mentioned before, new perfumes, facial creams, things like that, even lipstick sometimes. So there's four ways that a person can come into contact with these substances. Injection, probably going to be the bee sting or wasp sting, something like that. That will do it. Ingestion is the most common way people get into trouble this way. Usually they eat something they shouldn't have eaten. What I see with little kids is they have these little kids, they're 6, 7 years old. They have a very serious wheat allergy. And mom makes them the soy, vegan soy sandwich. And they go to school and they're at lunch with their little friends. And their little friends having a pastrami sandwich. And they change sandwiches. And now this little kid eats the wheat product. And then now they go into anaphylactic shock while they're at school. So ingestion. Inhalation is pretty rare, but you can inhale dust particles. If you had minute amounts of dust, type of like a latex, if you had latex allergies. One of my old partners, he had a severe latex allergy. And even if he breathed in the dust from the gloves, because years ago we used latex gloves rather than non-latex gloves, and even if he opened up a box of latex gloves, he could go into an anaphylactic reaction just from breathing this minute particles of dust in the air. And contact dermatitis or contact absorption, this would be something like, I would imagine the cream or the perfume, or even if they have a serious reaction, which is pretty rare, a serious reaction to like poison oak, I guess I could do it as well. So scene size up, scene safety. We've had some cases in San Diego. I don't know if you guys were around at the time, but we had the big killer bee scare, and we went through killer bee training and all that great stuff. There's been a couple incidents in the county where crew members have been stung while rendering care to people who were envenomated by hives of bees. There was 2 children in Penasquitos Canyon that were throwing rocks at a beehive. It's kind of like Darwin's theory of something there. I'm not too sure, but they got envenomated pretty good. And in the process of the firefighters and the paramedics rendering care, there were a couple of envenomations there. There was another case in Encinitas, very similar. A backhoe struck a tree that had a beehive in it, and the beehive actually wound up killing one of the workers. The poor worker decided to run into the porta potty to avoid this hive of bees coming after him, and unfortunately, as you probably already know, porta potties have little vents, and the vents are like bee size, and they went into the porta potty and they stung him to death. It was about I don't remember the whole story, but they said there was like 1,000 bee stings on him or something like that. I might be exaggerating. I don't know. So look at the hazard that you face, obviously. Medications at scene. If you arrive at scene and there's a half-empty bottle of penicillin or some new medication, that might be a clue. You never know. New creams, new perfumes, things like that, new bar soaps, things like that. Investigate what's going on. Not that it really totally matters what caused it. You're just going to treat it symptomatically. If you have the epinephrine pen and the oxygen, you're going to treat them the same way. But it's good to know what might have caused this so that they can follow up later. Now, like every single patient, primary assessment really revolves around airway, breathing, and circulation. Now, this is angioedema to the tongue. And I've seen this a few times in the field. I saw one lady last year, only half of her tongue was swollen like that. It was so funny. I didn't laugh, I promise. But imagine if this lady, one half of the tongue looked normal and the other half looked like a gigantic hot dog. But that's how it works sometimes. You never know. But you can see this could be a pretty good airway obstruction. People will complain of a lump in their throat, difficulty swallowing. If someone says, I got stung by a bee, or I ate a peanut, or I tried a new perfume, and now it's hard to swallow, that's a serious reaction. It's going to progress. It's going to get worse. it should be a clue for you guys to be aggressive with the epinephrine and administer it as soon as you safely can based on your protocol. Urticardia, that's the bumps, the little welts that people get on their skin, those little raised welts on their skin caused by the reaction. Pruritus is the itching. You should probably know those two definitions. Edema, of course, is the swelling like with the tongue, and this is caused by leaking capillary beds. So the excessive amounts of histamine actually cause your blood vessels to dilate and relax, and it allows this leaking of edema out through the walls of your capillaries into the surrounding tissues, leading to the swelling in their throat or their tongue or their face, essentially. And if they're in shock, if their blood pressure is low, they're going to have this rapid, weak pulse, or what we would call a thready pulse. I have encountered people in the field who have absolutely no other symptoms or signs other than a really low blood pressure. So if you have somebody who has a blood pressure that's, extremely low, I'm talking about like under 70 systolic, under 80 systolic, and there's no obvious reason why their pressure is low, you've got to think about this might be an allergic reaction. And so if there's no hives, there's no itching, there's no swelling, there's no wheezes, the respiratory system is fine, all that's happened basically is the body's released all those histamines, it's vasodilated all of their blood vessels due to this hypersecretion of histamines, and that's why the blood pressure is low. When in doubt, epinephrine works great. If you suspect, because it says suspected allergic reaction, or anaphylactic shock, why not, right? If you can't rule everything else out, and you think this might be allergic reaction, go for it. I don't think anyone would fault you for that. So secondary assessment, of course, sample history, what were you exposed to? And a really important question is how long ago? So if you have someone who was exposed to whatever they have allergies to, let's say 2 hours ago, and they said, I ate a salad 2 hours ago and I think it had peanuts in it, and now 2 hours later I'm starting to feel a little itchy and my throat's getting a little tight. You can almost guess that this is a really slow onset, and it's unlikely that that particular allergic reaction is going to progress into anything super serious. On the other hand, like the lady in the Thai restaurant, 5 minutes after she ate that salad, she began to be nauseated, and then she got the hives and the itches and the swelling to her face. So within 5 or 10 minutes, she's already in full-blown anaphylaxis. And that should tell you the time of onset. The faster that these reactions come on, usually the more aggressive they are. When it comes to a physical examination, we're going to use IPA, of course. We're going to inspect for the extension of the hives. So if this person has hives all over her arms and chest and back and shoulders and legs and face and neck and everywhere, you want to note that, because when you give the epinephrine and it does its little magic, those hives should start to recede, and it's an indication that the epinephrine is working. You also want to listen to their lung sounds and get a pulse oximetry reading probably really soon in this process. Truthfully, you'd probably want to do that during your primary assessment, but if you haven't gotten it yet, this would be a great time to do it during your IPA and get some vital signs: blood pressure, pulse, respirations. You should have already had them on high flow O2. This person is really not a candidate for a nasal cannula. They need the 15 liters per minute. Now, when it comes to treatment, you already know about the epinephrine pen. You know the doses, pediatric versus adult epinephrine. Some patients who have this have albuterol sulfate in an inhaler form, an MDI inhaler form. Per the County of San Diego, you can assist with one or the other. whichever the patient prefers. You'll have your own EpiPen on the ambulance, and they might have their own EpiPen on them themselves. Either way, you can tell them to inject themselves if they want to use their own pen, or you can do it with your own pen, whatever it might be. You can also assist them with their inhaler if that's what works for them. So if they're stable, ask them, see what's going on. If this was a bee sting or a wasp sting or something like that, you're going to find the stinger and you're going to scrape it out so you don't squeeze it and squeeze more venom in. You're going to take a credit card or some type of a plastic edge and scrape it off. Now, once you have their airway, breathing, and circulation stabilized, once you've administered the epinephrine and they're feeling a little bit better, all epinephrine does is epinephrine stops the life-threatening problems. It vasoconstricts, so it increases the blood pressure. It bronchodilates to reduce the wheezes and improve the amount of air entering the lungs. And it speeds up the heart rate to pump blood. So it's solving their circulatory and respiratory problems for now anyway. The problem is the antigen protein, the substance that they've been exposed to, is still circulating in their bloodstream. So you have not blocked the histamine release, you just masked it with this epinephrine temporarily. And if you give epinephrine given intramuscularly, it probably is good for about 15 minutes or so, and then it's going to start to lose its potency. So you got to time this just right. Ideally, luckily for us here in the county of San Diego, we have hospitals everywhere, we have paramedic units everywhere. So you could administer the epinephrine, load the person up, and get them to ALS pretty quickly. My point in all this is that if you don't have that capability, if you've got a long transport time, you're going to give them the EpiPen, and then if they have their own Benadryl tablets, and a lot of people who have allergic reactions, serious life-threatening reactions, carry Benadryl with them. And this is an antihistamine, as some of you might already be aware. And so once they're stabilized, and once you're in the back of the ambulance, if they have the Benadryl tablets, you cannot touch those tablets. They're not part of your scope of practice. But you can strongly encourage them to take it, as long as there's no airway compromise or make sure they can swallow and all that. Benadryl is an antihistamine, so Benadryl is going to help to slow down or block that secretion of histamines, and it takes probably about 10 or 15 minutes, maybe 20 minutes for the Benadryl to enter the bloodstream and get to work. So if you time these things, just about right, just as the EpiPen is starting to wear off, the Benadryl is going to kind of kick in, and hopefully it will keep them going until they get to the hospital and need more medications. So again, if they have Benadryl tablets, well, you can suggest it. Just don't touch the tablets. Don't hand them to them. Let them do the whole thing themselves and make sure they can chew or they can swallow the pills. There's your auto injector. You should hopefully by now be very familiar. Of course, we know it's alpha beta actions of the medication. So it's bronchodilation, it's increase of heart rate and cardiac output, and also you get the vasoconstriction properties with the epinephrine. 0.3 milligrams for adults and 0.15 milligrams for pediatrics. You'll carry one of each of these on the ambulance or fire truck that you might be working on. It's pretty fast onset. Once you inject this, they should start having improvement within about 3 minutes or so, about 3 to 5 minutes. You should start seeing marked improvement with this. And we want to give it in the lateral thigh. And remember, this needle is really big. It injects very quickly into the muscle. It's intramuscularly absorbed, and it hurts. So you want to hang on to that thigh pretty tightly. So you have one hand on the patient's inner thigh, and your other hand holding the pen. And when you go to administer that, you hold it against their thigh and push in until it clicks. It injects it very quickly and it's very painful, and they might have a tendency to pull away or get out. And what will happen is the needle will pull out of their skin and you'll lose the dose of medication. So hold their leg firmly and then stick them with the pen so they don't move that leg while it's being injected. Most pens usually will completely empty in about 3 seconds, but you can hold it longer. Count to 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. That should all be done. Pull it out, and then you put that in a sharps container, which you'll have on the ambulance. Now, reassessment. You look at, have the hives, are they starting to recede? If they had wheezes previously from the bronchoconstriction, is that getting better? Are their oxygen saturations coming up? Is their blood pressure coming up? Look, are they improving or not? They should be improving. It's pretty good drug, and like I said, in about 3 to 5 minutes, you should start seeing some marked improvements in the patient's status. Don't wait at scene for this. Get them moving towards the hospital or ALS capable unit like a paramedic unit or a fire truck or the nearest emergency room, because they need to be monitored for at least 6 hours. The problem with allergic reactions, they do go through a rebound effect, meaning that you give them the epinephrine, and even if they take their own Benadryl, assuming they have it, 3-4 hours later, they can come right back into anaphylaxis. So they need to be kept at the hospital for about 6 hours to make sure whatever is in their body has been eliminated, and the doctor can monitor them and give them more epinephrine and more Benadryl while they're going through this weeding out period, essentially.